sorry, my last stream kind of went weird. I ran out of battery, so I have to start up the stream again. So sorry if anyone was watching. Now, I have a lot of things I want to study today. Lots of so many amazing things to look into. Let me see if I can share this iPad screen with you. all set. Have a lecture today. So put this here. I'm going to. Perfect. guess I gotta turn off the display capture for this lecture. Oh, this is a radiology MSK session. Interesting, very interesting.
Hey everyone, it looks like we have about 114 or 15 participants logged in already, so I'm gonna go ahead and get started. Can everyone hear me okay? Awesome. So my name is Nancy. I'm one of the PGY3 residents in radiology, and thank you guys all for tuning in today. I know it's a weird time, and thanks to to Andrea and the pre-med program for arranging this for us. So today I'll be talking to you guys about MSK in terms of how radiology and anatomy kind of are integrated together. Special thanks to Dr. Mama and one of the other residents, Mallory Granholm, for providing these slides. So at any point, if you have questions, I'll ask you to, I'm going to be checking the chat box periodically. We're going to be going through these major body, body parts. After each section, I'll stop and check the chat box for any questions. I think Andrea should have emailed you guys a worksheet. So this is going to be kind of interactive. We're going to go through a lot of x-rays today, and you're going to be asked to label body parts on these x-rays. So if you don't mind, just either printing out the worksheet that we provided for you, or if you don't have the worksheet, that's totally fine. You can just use a blank sheet of paper or just like a Word document or anything like that. It should just work fine. And then when we take it up, if you feel like chiming in via audio, that's totally cool. Otherwise, feel free to just type in the chat box what you think the answer is. And again, if you have any questions at that point, feel free to type it into the chat box. This is my first time doing WebEx, so if there's any technical glitches, just please have some patience with me. And with that, if you guys have any questions, we'll get started. I'm not sure where, I think someone just asked where the slides will be posted after the lecture. Okay, yeah, Andrew's saying they're going to be posted. Great. Okay, and if there's any issues accessing the lecture slides afterwards, feel free to either email Andrea or myself. I'll just type in my email address right now. And we can help you get sorted in terms of figuring out where the slides are. And again, I left a message in the chat box at the start for you guys to do a feedback survey for us. It's like a quick 2-minute survey, and it really helps us figure out what your needs are and how to make these sessions better for you guys. Okay, so with that, if there's no further questions, I'm gonna go get started. So in terms of the objectives for today, we're gonna be reviewing MSK X-ray anatomy of the shoulder, elbow, wrist, hip, pelvis, knees, ankle, and foot. There's going to be some MRI involved with the shoulder, knee, and the ankle / foot, but these will be like the MRI are just like honestly for interest rather than for like formal objective learning. And then we're going to show a few clinical cases and wrap it up after that. Can everybody see my mouse okay? Okay, awesome. I'll touch base with Andrea after the session to get the slides posted then. I just saw that in the comments that Andrea doesn't actually have the slide. Okay, so as I said before, it's going to be an OSCE format. Each label, you'll get about 10 to 15 seconds. There's a timer at the bottom, and I'll check base with you guys in terms of if you guys feel like you need more time or less time as we go on. Is everybody ready with either a piece of paper, the worksheet, or the Word document? Just something to jot down their answers, essentially. Okay, sounds good. So we'll begin with the shoulder. Okay, we'll go on to the next slide. Oh, sorry, let me just, there we go. Next slide. If you guys feel like there's not enough time or too much time, just let me know in the chat box. Next slide. Oh, sorry, I don't think the timer was on. Okay, the next slide's up. Okay, so that was the end of the shoulder section. So the way we'll do this is we'll go through all the labels. And if people don't mind just putting in what they think the answer is in the chat box, that will be great. There's really no, I'm not marking you guys on this. This is totally for learning. So please don't feel like if you get it wrong, it's no big deal. This is all learning. So in terms of for label A, what does everyone think? So I see glenoid fossa, good job. Okay, label B. Yep, so label B is greater tubercle tuberosity, either is fine. And then that would make C. Yep, good job, guys. Okay, so these are, what do people think D is? Yep, coracoid process, good job. And then what is E? Awesome. So the way I always remember, I was always taught was that the acromion is like, in Greek, it's like Acropolis, and that's like the highest point somewhere in Greece, I'm presuming. And then, yes, these are AP views. And then so the acromion is the highest point on your shoulder. And if you find the acromion and on yourself, if you feel the acromion, which is the highest point on your shoulder, and then you come down more inferiorly, you're going to feel like a bony point on yourself, and it feels really uncomfortable pressing on it hard, and that's the coracoid process. And so for the next set of labels, what's F? Nice, good job, guys. So that is the F is the anatomical neck, and then what's G? Yep, good job. And then H, it's kind of like a generalized label of this entire bone, I think. Yeah, shaft. I think they were just going for humerus, but yeah, good job. So in terms of the difference, anatomical neck is where your growth plate fuses. The importance of the surgical neck is actually where most of the fractures happen. And there's a lot of, there's like the axillary nerve that goes through near this region. There's the circumflex arteries that go near this region, which is why this is an important surgical landmark for when you get fractures within the humerus. Okay, so we're gonna go on to a next set of labels. So these are lateral, this is a lateral view of the shoulder. And then we'll just start with I guess. So I is actually pointing to this structure here. That's kind of coming around, not really related to the shoulder, but yep, good job. So someone said rib, that's great. And then what is J? So J, I think they're trying to point at this structure here, coming horizontally. Yep, that's the clavicle, good job. And then K, we've had this before. Yep, that's the acromion, good job. And then L, it's kind of hard to see L just because on an x-ray, it's kind of, everything's overlapping together, but it's essentially this blue outline. Yep, someone said scapula, that is correct, good job. And then so on the lateral radiograph, we use this a lot for detecting dislocations. So depending on, so the head of the humerus, which you can see outlined here, should sit within this sort of Y structure, which is the scapula here. And if the shoulder, the humeral head is more anteriorly or posteriorly, that makes you suspicious for a dislocation. So this is called an axillary view. So essentially the arm is abducted or abducted away from the body. and the X-ray beam is actually coming through your axilla, essentially. This is a hard view for people to sort of get their mind wrapped around. So let's go through them. So what do people think M is? So M is actually the lesser tuberosity. I guess like one way to remember it is that the lesser tuberosity is more anterior than the greater tuberosity is usually back here more. And then what's N? So N is this thing outlined in blue here. So yeah, the answer is acromion. Not sure if there's a good way to remember this. But yeah, so N is acromion. In which case, what should O be? Someone already said it before. Yeah, coracoid process, exactly. And then P is this triangle structure here. I think it was one of our first labels. Glenoid fossa, yeah, exactly. So this view is great for looking for shoulder dislocation. Essentially, you're looking to make sure that the humeral head is sitting nicely inside the glenoid fossa to say that the shoulder is, like the glenohumeral joint is maintained. And when you can't see this, like when the humeral head isn't in the glenoid fossa, then you're like very concerned for underlying dislocation. Just colloquially, this has no sort of like backed up by evidence, but some doctors, like some emergency doctors, will say that if you're able to abduct your arm far enough to get this axillary view, chances are this view is probably going to be normal and you're probably not dislocating your arm. Just because in order to abduct your arm while your shoulder is dislocated is quite hard and quite painful. So that's the end of the shoulder MRI stuff. Sorry, I think I have a question. Can you point out the clavicle on this X-ray? It's hard to say where the clavicle is on this X-ray. I don't think it's a good view for the clavicle. You might get the distal end of the clavicle, but really, I don't think it's possible on this specific X-ray to locate where the clavicle is. If it is here, it would be like somewhere here, like in the very corner of the bone. Sorry, I'm just gonna go through all the questions. The name of the view, I just call it the X-ray view. I think there's like a formal name for it. But like usually if you're emerging, you're asking for this view, you can just write axillary view, rule out shoulder dislocation, and people will know what you're talking about. The next question is, why does it seem like the acromion is below the coracoid on this view? So again, so unfortunately, because X-rays are two-dimensional, like it's essentially you're taking a 3D structure, which is the shoulder, and making it into a 2D film, a lot of things become overlapped. So I wouldn't say necessarily that this is inferior coracoid. It's just the way that all the structures get overlapped together that it seems this way, if that's helpful. And then it says MRI, but isn't this X-ray? It's just that the next section will be at MRI. So we're now going to go through the MRIs now, just to see what things look like more in 3D. So this is a coronal view of the shoulder. So we're just going to go through some gross anatomy here. So your deltoid muscles are over here. So this is your humeral head. This is your this is your glenoid over here. And this is the spine, this is your scapula. This is the spine of your scapula, and this is your clavicle over here. Let me know if I'm going too fast. So in this case, this would be your supraspinatus muscle, and supraspinatus attaches to your greater tuberosity, which is over here. And then inferior to that, underneath your spine of the scapula, you have your infraspinatus and your teres minor. And then you have your ribs over here. And then this black stuff over here is your lungs. Again, this is mostly just for interest. I'm not expecting you to memorize what things look like or how things are labeled on MRI. That is way beyond the level of a medical student. So this is now the sagittal view. So if you were to look at the patient on its side. So again, this is, let me just orient myself. So this is your humerus over here, and this is your clavicle up here. So, and then over here is your acromion. And then so this is your scapula down here. So this is the spine of your scapula. And then so this is, again, your supraspinatus and your infraspinatus teres minor, so your rotator cuff muscles. Deltoids are all the way out here. Okay. Any last questions about the shoulder before we move on to the elbow? Okay, so I think Mike just asked, is there something helpful to distinguish acromion from coracoid? So acromion, again, I think of it as the highest point. Let me go back to the x-rays, because I think the MRIs are beyond this level. I would just burn probably one of the first images we did in your mind. Let me just see. This is probably a good one. So acromion, on an AP x-ray, acromion should be higher than the coracoid. I think one of you guys asked that earlier. It's only in the axillary view that things, in terms of what's superior, what's inferior, gets kind of screwed up. But on a standard AP radiograph, the acromion is the highest point on the shoulder, and the coracoid is just a few finger widths below the acromion. Yeah, exactly. So the axillary view is a little bit weird because it's abduction. And also the way the film is shot, it's not it's not an AP view where the top of the image is superior and the bottom of the image is inferior. So that's why it doesn't, the idea that acromion is higher and a coracoid is lower makes sense, essentially. And if you guys ever feel like I missed a question, please just use the audio, speak up, just because it's a little bit hard to keep track of. All right, so let's go down and do the elbow. Oh, sorry, I'm just trying to get the timer working. I'm not sure if I said it earlier, but essentially the timer is down here. Okay, next slide. So this is same view as the previous, just zoomed in more to get you guys to focus on E and F, which are two other structures. Okay, time's up. So this is a new slide. Okay, so that was the end of the elbow section. So what's label A? What bone is this? Humerus, love it. And what's B? Yep, lateral epicondyle, good job. And what's C? So this, I'll give you a hint, this is the radius. And it's pointing to this little bump here. Radial tuberosity, yeah, good job. Just to, in terms of how to differentiate radius from the ulna, the radius is bigger at the more distal aspect. So at the wrist, the radius is bigger. And then at the elbow, so the more proximal aspect of the radius is smaller than the ulna. So ulna is this bigger structure here. And then, D is medial epicondyle, given that B was lateral epicondyle. Are tuberosity and tubercle used interchangeably, or is there a difference between the terms? I think they are more or less interchangeable. In my daily use, I think of them as interchangeable. You might need to just look that up in terms of whether formally, if it's interchangeable or not. In my daily use, it is. Sorry, I don't think that was very helpful. Okay, so this is the zoomed in view of the same elbow. And what's E here? Capitellum, yep, good job. So capitellum always goes with radius. And then F, trochlea, yep, good job. Okay, so now the elbow is bent at a 90 degrees. And what's G here? So G is this little process here that's attached to the ulna. Orinoid process, good job, guys. And then what's H? I think it's pointing to the most proximal aspect of the radius here. Yeah, radial head, good job. And then I, your back of your elbow, oligocrenon, yep, good job. So this is a bonus question. Do you guys see any abnormality in this x-rays? This is not a completely normal x-ray. So the humerus is actually okay. There's no fractures in this film. It's more the soft tissues. I don't know if you're pointing at this region here as a possible humeral bone lesion. Unfortunately, sometimes this is just projectional. And because of the trabecular pattern within your bone, sometimes it just looks more irregular and more like I get what you mean by this kind of looks like a lesion here. In real life, I would compare this with other views. So like the views that we had back here, looking at the humerus to see if I see like a similar, essentially a correlate to this finding, to see if it's truly like a lesion versus it's just projectional. It's because of the trabecular pattern making it look like there's a lesion. So in this case, this is actually normal. Someone said anterior fat pad. That's a really good eye. So what Connor is talking about is this little triangle thing here that's a little bit slightly darker than the rest of the skin tissue. So anterior fat pad can be normal. It's normal to have that. It's when you have a posterior fat pad. So a fat pad, so a similar triangle structure that's darker than the surrounding soft tissues back here. That's very concerning for an underlying joint effusion. And in those cases, you're essentially scrutinizing the film until you find a fracture because you should not have a posterior fat pad. And the way I remember that is posterior fat pad is pathological. Both starts with P. So this can be normal. And then, so there's no fractures really. It's more about the soft tissues. And to be honest, unless I feel like you're really in tune with this, it's can be a quite subtle finding because usually we're so focused on the bones, right? Because it's an x-ray. So it could be bursitis, but really good eye. So there's a lot of soft tissue swelling back here, right? If you feel your own elbow, like this is why your funny bone hurts and all that stuff. Well, also because your ulnar nerve is back there, but essentially, usually you should not have this much. Like this is like probably a good inch or 2 inches of soft tissue swelling back here, right? Usually, if you feel your own elbow, it's just skin under, like skin and bones, essentially. I think someone said olecranon bursitis. That could certainly be the case, or it could just be underlying soft tissue swelling. We wouldn't be able to diagnose bursitis specifically on X-ray alone, but that's a really good differential. Okay, so that was the end of the elbow section. Any questions? Okay, we'll move on to the hand and wrist then. We'll go on to the next slide. Oh, sorry. And just to help orientate you, this is your radius here. Remember how I was saying the radius is the bigger bone, more distally, which means this is your thumb, if it helps to orientate you. Next slide. Same radiograph, just different labels. Okay, so that was the end of the hand and wrist section. So we'll go through the labels again. What's A? Middle phalanx, good job. And then what's B? Metacarpal, love it. Metatarsal is usually reserved for the foot, carpal for the hand. And what's C? Radius, good job. And then what does that make D? Ulna, good job. Okay, so now we're zoomed in more. What is E, this bone here? Hamate, good job. And what's F, this bone here? Lunate, yep. And G? Scaphoid, yep. Good work, guys. Okay, more carpal bones. What's H? Capitate, yep. Good job. So that's I was always taught capitate is the capital of the carpal bones, so it sits centrally, more or less. And what's I? So it's this blue outlined bone next to the lunate. Triquetrum, yep. And then J is pointing to this little tip of the ulna here. What's that called? Yep, good water. And what's K here? Trapezium, yep, good job. Trapezoid is the one that comes after. I also always get those two mixed up. Okay, any questions about the hand and wrist? Okay, we'll go on to the pelvis and hips then. Trapezium is under the thumb. I like that. That's a great mnemonic, or not mnemonic, but memory aid. I'm going to use that. Sorry, I'm just trying to get the slider to show up. Next slide. I'm not sure how well these images are projecting on your own screen, but essentially E is outlining this joint here, back here. The same thing with F, it's outlining this joint here. Okay, this is the next slide. Okay, we'll take up the answers for these. Oh, sorry, so that label came out really fast. So this is the iliac crest, which is A. What's label B here? So that's pointing at this little prominence here. Yeah, this is the ASIS. And what's C? So C is kind of pointing at this rounded structure at the pelvis. Yep, acetabulum. Good job. And then D. Inferior pubic rami. Yep. Good job. Okay. And just looking at Patrick had a question, epiphyseal, metaphyseal, diaphyseal distinction lining up with the anatomical surgical next. I'm not sure if that's always the case. I think the growth plate fusion, like so where the metaphysis would be, would line up with the anatomical neck. Surgical neck really is a term used for where fractures usually happen. Um, and yeah, I'm not 100% sure. I would have to look this up. I don't know if it like always lines up with anatomical neck being where the growth plate fusion happens. Okay, what's E? SI joint. Yep, good job. And then what's F? You don't have to overthink it in terms of what F is. It says it on the slide. Yep, good job. And what's G? Yep, superior pubic ramus. And then what's H? Pubic symphysis. Yep, good job. Okay, so this is a close up of the left hip. What's J here? So J is the femoral neck. Yep. And I think people are jumping the gun here. Oh, I don't know why the labels are being weird. Oh, sorry, I skipped a label. So yeah, I is the lesser. Sorry, that was my bad. So lesser trochanter is here, and J is the femoral neck. And what's K? I think people already responded to K as well. Greater trochanter. Yep, good job, guys. And then so the femoral neck helps you in terms of classifying fractures into different types of hip fractures. You might remember that the vascular supply for the femur, in terms of there's circumflex arteries that come down here and more supplies the hip, or sorry, supplies the femur with blood supplies more down here. And really at the head of the femur, there's that small, tiny artery. I think it's like the acetabular artery that goes in here. So if you have a femoral neck fracture that's more proximal, it's actually harder to heal because all your main blood supply is more down here. Is more distally down here. Would J also be the surgical neck? Yeah, that would also be the surgical neck. Yeah. Okay. So we'll go on to the knees. If there's no further questions about the hips. And I believe A is just asking you for what this bone is, if I remember the label correctly. And C is what is this structure here? I know it might be kind of hard to see on your screen. Okay, we'll go on to the next label. So this is a lateral view of the knee. Okay, that was a short 2 slides. Let's go through the answers. What's A? Tibia, good job. What does that make B then? Fibula, yep. And then C, this bone here, the biggest sesamoid bone in the body, yep, patella. What's D? Patella again, yep. And then what's E? It's pointing to this little, yep, tip top, yep. Okay. And then just a few, I guess, or not just a few. So in terms of if you were to look for joint effusions on an X-ray, they typically would show up here. So you're looking at the soft tissues. This is where your quadricep tendons, if you can kind of believe me, squint real hard, you can kind of see the outline of your quadricep muscle and then the tendon attachment to your patella. Usually, suprapatellar joint effusions would show up here, and it would show up more dense than the soft